The human body is complex. Pain signals don't always tell a simple story. Take cervical disc injuries and shoulder pain, two seemingly distinct problems that can manifest with remarkably similar symptoms. This overlap occurs because of the intricate network of nerves that run from our neck into our shoulders and arms, known as dermatomes. When a cervical disc herniates, for instance, it can compress these nerves, leading to pain that radiates down the shoulder blade, mimicking a shoulder problem. Similarly, trigger points, those tight, knotted areas within muscles in the shoulder, can send pain signals that travel up the neck, creating confusion about the true origin of the pain. This overlap in referral patterns often makes it challenging to pinpoint the root cause of a patient's discomfort. Is the pain stemming from a pinched nerve in the neck, or is it a shoulder muscle in distress? This diagnostic dilemma underscores the need for a comprehensive evaluation that considers all possibilities. Myofascial pain, originating from trigger points in muscles, and radiculopathy, stemming from nerve compression, often play a game of deception. Trigger points in the shoulder muscles, for example, can mimic the radiating pain of a cervical disc herniation. This similarity arises because both conditions can irritate the same nerve pathways, creating pain that feels like it's coming from a different location. Radiculopathy, on the other hand, often presents with additional neurological symptoms such as numbness, tingling, or weakness in the arm, which are generally absent in myofascial pain. However, the presence or absence of these symptoms is not always clear-cut, and there can be overlap. Understanding these nuances is crucial for accurate diagnosis and effective treatment. While imaging tests like X-rays, Connecticut scans, and MRIs provide valuable insights into the structures of our body, they don't always tell the whole story. A herniated disc on an MRI, for instance, doesn't automatically mean that the disc is the source of the pain. Many people have silent disc herniations that cause no symptoms. Conversely, a normal MRI doesn't rule out the possibility of a nerve being irritated by other structures, such as tight muscles or ligaments. This is why it's crucial to correlate imaging findings with the patient's clinical presentation, including their symptoms, medical history, and physical exam. Relying solely on imaging can lead to misdiagnosis and unnecessary interventions. Neurological symptoms, deciphering the clues. Neurological symptoms like numbness, tingling, and weakness can be particularly perplexing. While they often point towards a nerve issue, pinpointing the exact location of the problem can be tricky. For example, a patient might experience numbness down the side of their arm and into their pinky and ring fingers, known as a C8T1 distribution, suggesting a problem with the nerves exiting the spinal cord at that level. However, this symptom pattern could be caused by a nerve compression in the neck, a pinched nerve in the shoulder, or even carpal tunnel syndrome in the wrist. A thorough neurological examination, including reflex testing, muscle strength assessment, and sensory evaluation, is essential to differentiate between these possibilities. Physical exam, the importance of a hands-on approach. The physical exam is a cornerstone of diagnosing neck and shoulder pain. By carefully observing a patient's posture, range of motion, and palpating muscles and joints, healthcare providers can gather valuable clues. Limited neck rotation, for instance, might suggest a cervical disc issue, while pain with shoulder movement could implicate a rotator cuff tear. However, physical exam findings are not always straightforward. Certain movements might elicit pain in both conditions, making it difficult to differentiate. Furthermore, pain perception is subjective, and patients might have different tolerances and ways of describing their symptoms. Therefore, it's crucial to combine physical exam findings with the patient's history and other diagnostic tests. Diagnostic pearls, putting it all together. So how do we solve this diagnostic puzzle? The key lies in a multifaceted approach. Pay close attention to the patient's history. If neck movements exacerbate the pain, a cervical disc issue is more likely. If shoulder movements are the primary culprit, a shoulder problem is more probable. Neurodynamic testing, which involves specific maneuvers to tension nerves, can help determine if a nerve is being compressed. Finally, diagnostic blocks, where a local anesthetic is injected into a specific area, can be invaluable. If a nerve block at the neck relieves the pain, it confirms a cervical origin. If a block at the shoulder does the trick, it points towards a shoulder problem. By carefully piecing together all the clues, we can arrive at an accurate diagnosis and develop an effective treatment plan.